We have a video on shock, a concept that's kind of difficult to wrap your head around. Towards the towards the beginning of class, not the center of class, the beginning of class, especially when we start to teach patient assessment and making a determination of shock is something that we request our students to do towards the tail end of the primary assessment at the bottom of circulation. And without having too many visual references, and then, getting trapped in the thought of maybe I need a blood pressure. I remember when we first started teaching together, asking a blood pressure prematurely is something that I started to notice. And, I think having a discussion on what are some things that are seen, looked for, heard, maybe felt amongst the primary that can contribute to someone's determination of whether or not they're in shock. We might not have the systolic blood pressure to determine whether or not they're in compensated or decompensated shock, but a state of shock regardless.
Yeah, I think that recognition of shock is sometimes it's quite subtle. I think that people look for this kind of is it there, is it not there? And I almost come from the approach that shock is the ultimate bad guy in this story we're trying to tell. It's the antagonist.
Okay.
So, any disease arguably left untreated will eventually turn into that shock. And I think that recognition of shock it could be very subtle, or it could be very obvious. And shock is complicated because there are different causes. And with those different causes, there are different presentations. And even there's different definitions of shock. Depending on who you ask, what is shock, they might give you a different definition. I remember even when I was in EMT school, shock, also known as hypoperfusion. I remember in EMT school, they said shock is low blood pressure. And it's no, shock is not low blood pressure.
Hold on.
Shock was defined for me as low blood pressure.
Really?
And that's not shock. The definition that I usually share with the students, and it's not a perfect definition, but the one I like to share is it's the inadequate movement of nutrient-rich blood. So there's two components to that. There's the movement component, which we usually that's what we really sink our teeth into when we're talking about shock. It's the movement of blood, but we also need to consider the nutrients. And largely, when we say nutrients, we're referring to oxygen, glucose. You could substitute in ketones as well, but those are the two kind of nutrients that are necessary for perfusion. So I think that one of the fundamental things to understand when you're talking about biology, human biology, pathology, is cellular respiration.
Okay.
Or respiration in general. So respiration is often described as the exchange of gases. So what that pretty much means is oxygen in, CO2 out. One thing I do in class, and I think I mentioned this in our our airway video or our respiratory ventilation video, I do not call ventilations respirations. I say ventilatory rate. Yeah. I don't say respiratory rate, because when I hear, a respiratory rate, I'm thinking rate of respiration. And respiration is the creation of ATP. And, I have this little kind of formula written here on the screen. And this is something I share with the students, and I say that this is cellular respiration. So this is, when you boil, it's not the meaning of life. I can't tell you what the meaning of life is. But when we think about one of the most necessary things that have to happen in your body constantly, or there will be no life, is this formula. You cannot live without this. So it's oxygen plus glucose. You could also have ketones in there. And these two things come together, they enter in the cell, and with the help of the mitochondria, they produce ATP, CO2, heat, and water. The main product here is ATP. This is the energy molecule. This is what you need. This is the gas that your body runs on. And CO2, this is the CO2 we exhale. So this is the O2 we inhale, and this is the CO2 we exhale. And I think that it's really important to understand this. If you're trying to understand perfusion, you're trying to understand the movement of kind of blood throughout the body, this is what you need to see. So we have our alveoli here. We take a breath, and the air that we breathe, roughly 21% of it is oxygen. This oxygen is going to move from the alveoli into the bloodstream. It's going to make its way to the left side of the heart. Now this oxygenated blood is going to pump out the left side of the heart, and it's eventually going to make its way to a cell. And this oxygen is going to enter the cell right here, as well as glucose, and it's going to produce ATP. Again, that's that energy molecule that our body needs to survive. This is the goal. This is the purpose. But it's also going to produce CO2, which is a waste product, heat, and H2O. So the CO2 is going to leave the cell, make its way to the right side of the heart, and eventually make its way to the lungs, to the alveoli, where it's exhaled. So the way I usually describe this to students, because I really understand that we have people coming to this class who have different backgrounds in terms of like they have experience with different types of sciences, and they can really think sciencey concepts up, but that's not everybody. Not everybody has had that exposure. So the way I kind of explain it is oxygen, they're trying to make their way to work, and they get to the alveoli. This is where they wait for the train. They hop on the train, which is the bloodstream, and they take this train around until they get off at work. They work at the cell. They have a co-worker, that's glucose. These two work together to produce ATP. When oxygen is tired and it's done working, it's now CO2. Now the CO2 is hopping on the train and riding it back home where it's exhaled. So it's pretty much the red, the oxygen. This is oxygen wanting to work. The CO2 is the oxygen that's done working for the day. The glucose is worked to death. They're gone. But if you kind of think of this cycle in that everything, this is dependent on everything. That this process must continue constantly, or you don't have life. And, when you think of ATP is necessary for active process. So I think when we think of an active process, we usually think of like walking, moving, exercising, but even things like thinking, that's an active process. But most of your ATP is consumed by something called a sodium-potassium pump. So in your cell, sodium wants to rush into your cell, but that's not a good thing. We need to pump that sodium out, because if sodium rushes into the cell is going to explode. So most of our energy...
Explode because what? Water will follow it?
Water follows sodium, So the technical term, I guess, is called lyse. It's lysing.
Okay.
So a lot of our ATP is consumed just there. So if you don't have enough ATP, pretty much all your cells are going to explode. So it's really, really important.
So the cell is utilizing ATP to pump sodium against its gradient out of the cell.
Yeah.
Okay.
Yeah. Which is a thing, probably a concept for another video. Active and passive diffusion.
I'm sure there's Khan Academy, plenty of videos are doing it justice.
So, but if you don't have that ATP, the idea is that, yes, you're not going to be able to do those active processes, but you will also die, right? Wow. So it's not like you're just going to be tired. You're dead meat.
Okay.
So when we think of, circulation, I like to think of it as this train moving around the track.
Okay.
The train's picking up the oxygen.
It's the first time I heard that analogy.
Yeah, I've been using it for a few
It's great.
years. So the train's picking up the oxygen's going to work at the cell. Once the oxygen is done working, it's CO2, and this train is taking it back to the train station. So this is a really important concept to understand, and it's also important to understand that a lot of stuff can jack this up. Anything that robs blood flow, oxygenated blood flow to the cell, is going to create an issue. And biggest thing being is a concept called hypoperfusion or shock. So again, perfusion is defined as the adequate movement of nutrient-rich blood throughout the body. That's a definition I use.
If we were, and we'll have a whole segment towards the end of the video, but like just by using the image in the screen, if we were to start thinking about hypovolemia, well, are they low volume because of diarrhea or vomiting, or are they low volume because they're bleeding somewhere, externally or internally? What about distributive? When the vessels dilate, maybe the people, the workers, don't get to where they need to get, right? They land somewhere else.
Yeah, and the big thing is, what is going to stop oxygen from getting here? What is going to stop the blood from getting there?
If you can wrap your head around like what that causes, I think you're in the right direction of officially labeling it. So like if there's an obstruction, maybe it's obstructive shock, right? If the vessels have dilated, maybe distributive shock. So when we look at shock, I think one of the other kind of concepts to understand is this notion of cardiac output. So cardiac output, which is CO here, is the amount of blood that your heart ejects out in 1 minute. Okay.
So if you have adequate cardiac output, you have adequate perfusion. That's more or less, we're jumping some things to come to that conclusion. But if you have adequate cardiac output, we're going to say you have adequate perfusion. So cardiac output is stroke volume times heart rate. So stroke volume is the amount of blood your heart ejects out in one beat. So every time it beats, that's a stroke volume. And then heart rate is the amount your heart beats per minute. So it's your beats per minute. So let's think of this concept of hypovolemia. And I think one of the best ways of thinking about hypovolemia is through bleeding, because it's the easiest to display. So on average, your cardiac output for most people is about 5 liters per minute. So that means every minute your heart is ejecting out 5 liters of blood. So blood gets ejected out, and then it gets used up and it's returned to the heart. So 5 liters go out, 5 liters return. That's a normal situation. So every 5, for me, I probably have a little more blood because I'm a little more thick, as you could say. But I probably have a little more than 5 liters of blood. But let's say every minute 5 liters of blood is being ejected out of my heart. Every minute 5 liters is returning, right? So let's say someone is bleeding. So this could be this person shot, stabbed, gets in an accident, and they're losing 0.5 liters of blood a minute. So that means if they're losing 0.5 here, that means only 4.5 is going to return. So that's a kind of an easy concept to understand. 5 liters is coming out, but they're losing 0.5 here, so only 4.5 is returning. So that means that their max cardiac output now is going to be 4.5. So now, a minute later, 4.5 liters of blood is leaving the heart, but they're still losing this 0.5.
Sure.
So that means only 4 is returning. That means only 4 can pump out. Another minute later, they're at 3.5, and then 3, and so on and so forth. And we see as long as this blood continues to leave here, it's not returning to the heart. So what that in essence is doing is dropping this cardiac output. And a drop in cardiac output, inadequate cardiac output, is going to be inadequate perfusion. So that's kind of how hypovolemia works. You're losing this capacity to carry blood. So there's 2 types of hypovolemia. There's hemorrhagic, which is caused by bleeding, and there's non-hemorrhagic, which is like diarrhea, dehydration, malnutrition. Arguably, hemorrhagic is worse because it is quicker. You're losing that blood at a faster rate, and the body doesn't adjust that well. It is more difficult to stop. Sometimes, like when we're thinking EMS, if someone has a really bad bleed, it might be a surgical intervention that's necessary to stop this bleed. And they're losing whole blood. So they're actually losing that
oxygen carrying capacity.
Yeah, they're losing oxygen carrying capacity. When someone is hypovolemic, really, I mean, you want to stop what's causing that, right? You want to stop like the nausea, the vomiting that's causing that. But all this person really needs is fluids in their system and maybe some electrolytes and stuff like that. But this individual who's bleeding, they need blood replacement because it's not just the loss of, of that movement, but you're actually losing whole blood there as well.
If you were to stay on that same page real quick, like as a note to when someone is in a state of shock, our body is very resilient, and one of the hallmark signs is going to be tachycardia, elevated heart rate, elevated ventilatory rate. And if you look at that equation, cardiac output equals stroke volume times heart rate. Well, if we're losing volume, so the stroke volume is going down, you're going to, to try to maintain that cardiac output, that heart rate's going to elevate.
Yeah. So most of the signs and symptoms that we actually see in shock are due to what you're describing, compensation mechanisms. So there's 3 stages of shock that I'll talk about a little bit at the end, but there's compensated, decompensated, and then multiple organ dysfunction system, also known as irreversible shock. When you have an issue, your body is going to try to fix it. But depending on the cause of shock, they might not be able to do certain things.
Okay.
So, kind of brings me into my next type of
you
shock.
had it lined up.
I like to talk about, and that's kind of cardiogenic shock.
Okay.
So, cardiogenic shock is when the heart is the problem.
Yeah.
So, your heart is your driving force for moving blood, right? Without your heart working efficiently, you can't drive out that blood. So, we call it cardiogenic when the heart itself is the problem. It's the heart. It's not any external.
Like what
issues.
are two examples?
So the common problems will be like heart failure, typically left-sided heart failure. Someone has a difficult time pushing out that blood. Cardiac dysrhythmia is another big one. So a heart rate that is not sufficient in its numbers, so it could be far too high or far too slow. And another one can be just like a heart attack that puts someone into a heart failure. The ventricles aren't pumping properly. So cardiogenic, like I said, it's a heart-specific issue. The heart is broken, and that's not because your loved one of 3 months dumped your ass. It's because your heart's sick. So there's a few different things that can happen. So I described like heart failure. Like let's say you have a massive MI and it makes your heart weak. So your left ventricle is weak. It's not pumping out blood as efficiently or as strong as it once did. So that is going to drop stroke volume. If you remember, stroke volume is the amount of blood that gets ejected out of the heart in 1 minute. So if your heart's weak
in one cycle,
one pump,
Yeah.
not 1 minute, one contraction. So if the stroke volume drops, well, cardiac output's going to drop, and if cardiac output drops, then we're having issues with perfusion. So we can also have a situation in which someone, has a slow heart rate. So slow heart rates are usually due to cardiac dysrhythmia. It's usually due to like a heart block, or someone has like a, idioventricular rhythm or something like that. Just a slow heart, irregular heart rate. Kids tend to have low heart rates when they're hypoxic, but adults, it's usually due to cardiac dysrhythmia. So your heart rate drops, well, that's also going to drop cardiac output. So, but we do need to understand that cardiac dysrhythmias on the other end of the spectrum can be dangerous as well. So if your heart rate is far too fast, that is also going to drop cardiac output, because that's going to significantly reduce stroke volume. So the way that this was explained to me, so if I'm going to back up just a second. So if I clap, you can hear my clap. There's a good volume, good rate of speed, good volume. But if I speed that clap up, you don't hear the volume as much. You're losing the volume. And that's essentially what's happening. Your heart rate is beating so fast that you're losing stroke volume.
We did CPR today, and it's like that's the whole idea of allowing for chest recoil, just giving enough space and time for blood to completely refill the chambers of the heart prior to the next compression.
And typically the value where we start to get worried about heart rate, because like tachycardia can be a sign that someone's in distress, right? Where tachycardia starts to be like, okay, this is probably a real issue, is about 150. When we're seeing, I mean, it could be rough on the heart, but as soon as we're hitting 150, now we're into like the more serious dysrhythmia. So a very, very high heart rate will drop stroke volume significantly, which will drop cardiac output. So, you know, I will go through kind of each specific things, but just as like a preview. So like Victor was saying here, with hypovolemia, the body's going to try to compensate that. So what we're in essence seeing here is in this situation, our stroke volume is dropping, right? So this is back to the hypovolemic shock. Our stroke volume's dropping because the return of blood to the heart is dropping. So to compensate that, the person's heart rate is going to increase. And this increase in heart rate is going to pretty much attempt to compensate for that drop in volume. Don't know what happened there. So your body's going to compensate for that drop in stroke volume by increasing the heart rate. So this might be a little more complicated though in terms of compensation. So like we ask students, like, how do you recognize shock,
a state of shock?
And people often say, well, increased heart rate, that's a sign of shock. Well, what if somebody's overall issue is what's creating the shock is bradycardia? So in cardiogenic shock, you might have a pulse rate that's 30. Does that mean that this person's not in shock? Even though traditionally with shock like hypovolemia, you'll see an increased heart rate. So there are differences in signs and symptoms.
Similarly to skin conditions, right?
And here we are with distributive shock.
Yeah. So
distributive shock kind of ties into massive vasodilation. The way I like to describe distributive shock, I'm a proud suburbanite now. And one thing you do when you get old and move to the suburbs, you start to garden. And I'm a big gardener. And so I use the garden hose all the time to water all my plants. And I turn my spigot all the way on, and I'm able to water everything with an adequate amount of pressure. That's like an adequate tone blood vessel. Well, blood vessels can constrict and dilate based on different factors and different needs of the body. So, for example, if you are, let's say you're going for a run, or you're doing like a stair climb, the blood vessels in your legs are going to open up because it wants to feed more blood to your leg muscles, and maybe the blood vessels around your GI tract will constrict a little bit because you don't need as much blood flow there. So in distributive shock, there's two major causes of distributive shock, and they're both tied to inflammation, and that's anaphylaxis and sepsis. So what ends up happening is this normal red blood vessel turns into this big blue one right here. Another way I explain that, because sometimes we have firefighters who come through the program, it's like turning a garden hose into a fire hose. And it's like turning something with a diameter that's like this big.
But it's meant to be a garden hose.
Yes.
Yeah.
To this big. So it's like taking a garden or a fire hose and connecting it to the little spigot I have in my backyard.
Yeah.
So I'm not even going to be able to generate enough pressure for water to exit the other end potentially.
Yeah. Oh, wow.
Or another way of kind of thinking about this is like, let's say some people still use straws, some people don't, but let's say you're using a straw to suck up a drink. So what if you replace that straw with a paper towel roll? Are you going to be able to suck that up? No, because there's not enough pressure. Yeah. So what this is called is a drop in systemic vascular resistance. And with that drop of systemic vascular resistance, you're going to have a major drop in blood pressure. Blood pressure is not everything, But if you have low blood pressure, you probably don't have adequate kind of movement of this blood to the tissues. Pretty much we say like adequate blood pressure is likely to be adequate cellular perfusion. Inadequate blood pressure is less likely to be, or not likely to have good cellular perfusion. So we have a drop in blood pressure. So this concept right here, this is distributive shock. And you mentioned one thing is that the skin condition. So typically with shock, we see pale skin. And the reason we have pale skin is because our body's like, hey, we're low, like let's consider this hypovolemia again. So this person's like, we're losing blood. Let's not waste sending blood to the skin. Let's keep it to the core where it's needed. So it's going to constrict the blood vessels in the skin, which is going to present as paleness. Well, this person can't do that. All their blood vessels are dilated. They can't constrict their blood vessels. So usually someone who is in a distributive type of shock will be flush
and
to
is
normal
that
color.
due to that permeability, the capillary permeability?
Not the swelling can be, but this is just vasodilation.
So it's not like what's leaking into the tissue? What's causing that edema? But you're saying the blood is in the vessels and that's causing the flush visual?
Typically, like I said, this is inflation or not inflammation driven. So what you'll have, so let's say you're stung by a bee, right? And you look at the bee sting and it's red and swollen.
Yeah.
So two things are happening. This is an inflammatory response. One, you have increased vasodilation to that area. So that means more blood flow to that area, which is going to cause it to be red. But you're also going to have increased capillary permeability, which is going to cause water to leak out of the capillaries. And that's what causes the edema or the swelling. So edema...
Well, first of all, to make things make sense, like why do we want capillary permeability, or why do we want vasodilation at that site of the bee sting or mosquito bite, spider bite, whatever it is?
So when we get like bit by something, or like let's say a paper cut, I think that's a better example. You get a paper cut, it's red and swollen, and the reason why is on that paper cut you had there's probably bacteria on that paper. So you have bacteria in that cut. So we want to neutralize that bacteria. So what our body's going to do is it's going to increase blood flow there. So with that increase of blood flow, you are going to have more white blood cells going there to fight infection. And that increased blood flow is pretty much caused by that vasodilation. And then we want those white blood cells to be able to easily leak out of the system through the capillaries. So we have increased capillary permeability. Increased capillary permeability do a few different things, but when we see in terms of like infection and allergic reactions, it's water generally leaking out. And edema sometimes they call edema swelling. Not really. Edema is pretty much water leaking out of capillaries because like we have pulmonary edema. And pulmonary edema is water leaking from the pulmonary capillaries into an alveoli. So it's water leaking out. So with distributive shock, you're not going to have those skin condition changes. Yeah. So I did display on the side here kind of what happens when your blood vessels get too small. So you might say, well, why not just have constricted blood vessels all the time if that increases perfusion? So that's
traffic jam.
Yeah, well, a lot of things. So we have an increase of systemic vascular resistance, which will be an increase in blood pressure.
Yes.
Whenever you have an increase in blood pressure, that it actually increases afterload. So that's the amount of pressure your heart needs to overcome to eject out blood. Okay. So your higher your afterload, the harder your heart has to work. And arguably, if your afterload is too high, it's going to drop cardiac output. So you might run into a situation where this afterload is actually dropping perfusion. Like you have high blood pressure, but not a lot of blood moving out of the heart. So it's a complicated, cyclic
There's definitely a sweet spot, despite how resilient our body is.
Yeah, and I think that like in terms of high blood pressure, there's a lot of bad things it does to your body. It's really bad for your kidneys. But one of the acute issues with high blood pressure is if you have someone who's not very heart healthy, and their blood pressure is increasing, that means their afterload's increasing. That means the heart has to work harder to eject out blood. And if the heart could be working so hard where it's like someone who's in shape, they're running a mile, that, you know, or doing a marathon run. So someone just to perfuse, their heart might be beating like that. That's not good.
Can't sustain that. Yeah.
Okay. So the kind of the other cause of shock I wanted to talk a little bit about is obstructive shock. So the two examples I like to use for obstructive shock are tension pneumothorax and pericardial tamponade.
Yeah. Do you disagree with the PE?
Well, so when you look at the classic definition of shock, you don't really, or obstructive shock, pulmonary embolism is not like, it doesn't really fit the same.
The definition is like a backup of blood flow, or like the blood flow through the cardiopulmonary circuit has been obstructed?
So that it's a physical obstruction in the circulatory system, which is reducing blood flow. And it actually can result in hypoxia, which is arguably a type of shock as well.
So it's like an indirect obstructive shock in a way?
Yeah. And I think that when you look at tension pneumothorax and pericardial tamponade, it's easy to understand.
It is, yeah.
So with tension pneumothorax and pericardial tamponade, so tension pneumothorax is a significant amount of air collecting in your thoracic space, which is putting tension and pressure on the heart as well as the blood vessels, returning blood and blood ejecting out of the heart. And pericardial tamponade is fluid collecting in the pericardial sac. So your heart sits in this bag. And all those things are putting pressure on the heart and pressure on the blood vessels that are coming off the heart. So I like to say it's like something bear hugging the heart and those blood vessels. So what that's going to do, if you're bear hugging the heart can't eject blood like it needs to because it's being restricted.
Is it true that medics used to be able to treat tamponades?
Yeah, pericardial stentesis.
Like
it was something that they did in the back of the ambulance. It's not even something they do that often in the emergency room.
What's the care now? What's the intervention?
Well, what they try to do is they try to give medications.
Send them to oh really?
To but if it's like hemorrhage, they need to go to surgery.
Well, what if it's causing severe obstructive shock?
Well, yeah, it's still an option.
Okay.
But it's a.
But I wonder if they do it in the comfort of like interventional radiology or.
Yeah, I mean, well, you need an ultrasound, pretty much, for it to be effective. I mean, what they used to teach us is you insert this large needle, right below the xiphoid process, kind of like right where the diaphragm is, and you look at your cardiac monitor, and once you see a bleep or a little blip, a little bump, you're like, oh, you're in, and then you should be able to draw blood. And if you can't draw back, you're probably in the myocardium, so pull back a little bit, then you should be able to draw blood.
Oh my God.
I mean, that's crazy, but it's also like that should be a sterile procedure. Or a more sterile procedure. And that's not something that you shouldn't do or should do without any imaging.
Ultrasound
So the imaging helps a lot. But pretty much this pressure on the heart is dropping stroke volume.
Okay.
So with this drop of stroke volume, you're going to have a drop of cardiac output.
Okay. Yeah. That's great.
So I think that when you look at shock, after we consider all the causes of shock, I think then we look at arguably we start to look at the signs and symptoms of shock. So you want to look at the stages of shock. So really, there are two stages. There's a compensated state and a decompensated state.
Well, before we go that deep, what are some of the things like skin parameters or the quality of someone's pulse that you're looking for? Does it all matter? Like patient positioning, mental status, pulse ox, like that all matters, right? But like, I guess to be more clear or direct with our students earlier on, what should they be thinking about when considering shock in the primary?
So in your primary assessment, you should know whether or not someone is shock or at least a possibility of it. So with shock, depending on what stage you're in, you'll potentially have mental status changes because you don't have adequate blood flow to the brain. You'll potentially have skin condition changes. So largely we're looking for pale skin, cool skin. And one thing that I teach students, it's not really skin color that you should be focusing on. It's like conjunctiva, nail beds, because if you have a darker pigmented patient, it might not be as obvious, but it might not be as obvious, period.
Meaning, so what would the conjunctiva or the nail beds look like?
So normal conjunctiva are going to be pink.
Okay.
So if they're a pale color, then that can indicate paleness. But they'll also, the skin might feel cool. In some circumstances, it could be sweaty.
Is that because of the shunting as well of
the sweatiness is more so
peripheral?
caused by the adrenaline, epinephrine in your body.
No, the shunting of the cool.
Yeah, cool will be shunting as well. Yeah.
Okay, and then the release of adrenaline is causing that diaphoresis, the sweating.
So you're also going to often see increased heart rate. So increased heart rate is commonly seen with shock. And you also might see things like increased ventilatory rate as well. So, I mean, for me, that it's easier for me to understand shock by kind of, or the signs and symptoms of shock by really breaking it down into the different types. So if we have, like compensated shock, I'm just going to put CS for compensated here. Let me get a little bit thicker with the pen here. Okay, so I like to break it down into the causes of shock or the stages of shock when I'm thinking about like signs and symptoms. So for compensated shock, that essentially means our body is fighting the shock and it's winning. So we're going to see an increased heart rate. So you're going to see that heart rate increase. You're probably going to see an increased ventilatory rate as well. So we'll see an increased ventilatory rate. And the reason why we have an increased ventilatory rate is because the body's saying like, hey, we don't have enough oxygen or we're losing, the movement of blood. So let's try to like hyperoxygenate ourselves. You're probably going to see things like anxiety. And the anxiety is going to be, someone could be anxious with the condition they're experiencing. Like, if someone is having anaphylaxis, they're going to be scared because they can't breathe. But also your body is dumping adrenaline. And adrenaline is really what is pretty much mediating this response. Compensated shock is the fight or flight response. That's what your body is going through. So anxiety is usually a part of that. Pale skin is commonly seen, and this pale skin is because your body's saying, hey, we don't have enough blood flowing to our vital organs, so let's not send blood to the skin, let's keep it to the core. So paleness is a common thing you'll see. And I would argue that, in terms of blood pressure, and again, we tend to think of blood pressure as being the ultimate sign in terms of perfusion. Blood pressure should be normal here. So in a compensated shock, we should really have a normal BP. So there are some subtleties that you need to be aware of, though. So if we have a cardiogenic shock, you might not have an increased heart rate. Another type of distributive shock that we didn't really talk about is going to be our neurogenic shock. And typically with neurogenic shock, you don't have an increased heart rate either. In terms of pale skin.
What about, I guess I have it stuck in my mind that it's like the area above the spinal cord injury is unaffected.
Yeah, if it's a spinal cord injury, because it could be a brain injury as well causing that. But yeah, so...
Okay, right. So, the higher up it goes, then it might have more of a systemic effect.
So the argument why you don't see an increased heart rate as much with neurogenic shock is because your spinal cord is responsible for triggering the sympathetic nervous system, and your sympathetic nervous system is going to what increases the heart.
So the higher the injury, the more systemic in a way.
The higher,
or like if it's like above, brainstem and above.
Well, the kind of if you have a complete transsectional spinal cord injury,
Yeah.
that's going to affect your sympathetic nervous
Yeah.
system. So that could affect heart rate. In terms of skin conditions, your distributive types of shock, you really shouldn't see this pale skin.
Yeah.
So like anaphylaxis, on anaphylaxis, what we're going to notice is like urticaria and this rash, potentially, not always. Sepsis, you're not going to see pale skin. And then the neurogenic shock, let's say it's caused by a complete transsectional spinal cord injury, and this is kind of interesting. You may have pale skin above the injury,
Yeah.
but below
So
the injury.
is that like most commonly car accidents?
That's a common mechanism of injury, but gunshot wounds to the spinal cord, falls.
Where they can't get up, maybe lost feeling in their legs, but they look pale, cool, diaphoretic from injury above.
So if you have those like differences in skin conditions, which would be, I mean, I've never seen it before.
Gotcha.
But that is something that we definitely teach as a possibility. But with those distributive shock, you might not have those changes. So we look at a lot of these signs and symptoms, and most of these signs and symptoms are just compensation mechanisms. Because in compensated shock, we still have this working. So this is still working. The oxygen is making its way to the cell, but we have to do extra things to get this to work. So the other stage of shock that we see is decompensated shock. So decompensated shock, we're still fighting the battle against shock, but now we're starting to lose. So often with an adult, you're going to actually see a heart rate that is very increased here. If we're talking pediatric patients, it's likely that the heart rate is dropping. So with our peds, we're probably going to have a drop in heart rate. In terms of ventilatory rate, usually that's going to be elevated still as well, maybe even elevated to a greater level. We start to see AMS here.
That's a ventilatory rate, or?
Oh, yeah, my bad. So, yeah, ventilatory rate. Just erase that real quick. Victor can fix this in post. So, our ventilatory rate is probably going to increase with the non-compensated shock. And I don't know why I put a D there.
Decompensated
yeah,
shock?
decompensated shock. That's it. So ventilatory rate's going to increase even more with decompensated shock. Instead of anxiety, you're probably going to, like in terms of a mental exam, you're probably going to see AMS now. So AMS ranging from confusion to unresponsiveness. And that's now because the brain is not getting an adequate amount of blood flow, thus not enough oxygen, not enough glucose. In terms of skin, you might still see pale, but you also might start to see cyanosis develop because of this kind of total, collapse or pending collapse of the cardiopulmonary system. You're starting to see that tissues are becoming hypoxic. And that's like the consequence. Lack of blood flow, tissues becoming hypoxic. So you might start to see cyanosis develop. And then one thing you'll see, and I pretty much say that the two major things I think about when deciding whether or not someone is compensated or decompensated is blood pressure and mental status. Mental status being something we get in the primary assessment. I like to say someone's mentation is a window into their overall condition. So like when we're talking to a patient and they're confused, we know the brain's being affected. And if the brain's being affected, well, the kidneys are probably being affected. The, heart's probably being affected. The liver's probably being affected. But we can't as easily interact with those organs. Very easy to interact with the brain. You just talk to somebody. And if they have AMS and we're thinking shock, it's probably going to be decompensated. And that could be confirmed with the blood pressure. So the third stage of shock, it used to be called irreversible shock. There's a few different things we call it now. Multiple organ dysfunction syndrome, multiple organ failure. There's a few different terms for it. But pretty much what it means and why we used to call it irreversible is, let's say we have somebody who was in a really bad car accident. They lost a lot of blood. They get them to surgery. They stop all the bleeding. They give this person pints upon pints of blood, and their perfusion's back up to normal. But because they were in a state of hypoperfusion, low blood flow for such an extended period of time, maybe their kidneys are now failed. They have kidney failure because the kidneys didn't get enough blood flow, and now the kidneys are sick. Maybe this person has permanent brain damage because their brain didn't get enough perfusion for an extended period of time, so now the brain's sick.
Yeah.
So irreversible meaning like irreversible damage.
Gotcha.
And it's not always irreversible damage. Like kidneys can maybe heal themselves. The brain maybe through rehab can heal itself. But there's this lasting damage after perfusion increases.
Gotcha. Yeah, we don't. I mean, in lab we don't talk about that too much.
So I think that when you look at shock, you're like, holy shit, what can I do to, fix this problem? And to be honest, when you're talking about like decompensated shock, it might be, it might be limited in terms of what you can do. I would say first and foremost, if you're thinking of treating shock, just shock, there's 3 things you want to do. You want to keep them flat.
Yeah.
So keeping someone in a supine position will help the flow of blood.
And how many don't tolerate being supine?
So yeah, there are some patients who won't tolerate it. So patients who are, really bariatric, people who kind of are very obese, laying them flat on their back might affect their ventilatory effort. Additionally, people who are having a respiratory problem with this shock, lying them flat on their back can be dangerous. People with heart failure, lying them flat on their back can be dangerous. So in that situation, I would say instead of lying them flat, can they tolerate like a low Fowler's where they're just kind of on a bit of an incline? So the next thing we want to do is if they need oxygen, give them oxygen, right? We don't want to over-oxygenate somebody. Because if we're talking about, like somebody whose SpO2 is like reading, and you're not going to get this reading, because if someone's truly in shock, you're going to get a low SpO2 reading because you're going to have low perfusion. But like if for some reason somebody's SpO2 is reading 99% and you trusted your equipment, I wouldn't be throwing that person on oxygen. But make sure you're ruling out the kind of whether or not this person needs to be ventilated or given supplemental oxygen. And the one thing that everyone forgets to do is keep them warm. When you say everyone, this is something you noticed out in the streets, in the field? All the time. Really? We have people who have multiple gunshot wounds. We're cutting off their clothes. Which you need to do. Yeah. But we're trying to control this bleeding. But what we should be doing while we do that is blasting the heat in the back of the ambulance. Because if someone is becoming hypothermic, which they will become hypothermic if they're losing their blood, there's not a chance in the world you can save them. So it's really, really important that we're keeping these patients warm. And again, like when we talk about trauma, they're wet often from the blood, or just being outside laying in a puddle or whatever, and they're also exposed. Yeah. So turning on that heat is really, really important. And it's not that we don't care about their comfort. I just don't think we're well informed enough. And, recently you and we added that into our primary assessment, that hypothermia is part of our primary assessment now because it's an immediate life threat that should be managed. Yeah. I think we've been doing a better job at looking for these despite non-extreme temperatures outside. Yeah, it doesn't need to be negative something to get hypothermia, especially when we're talking about that being paired with hypovolemia. So, and I think when we think about treatments... Well, are there conditions like anaphylaxis that might cause a warmer, if not hot, temperature? So potentially, and that's going to be tied to your kind of compensation. So when that fight or flight response is going, one of the things that might happen is an increase in temperature. But consider sepsis. So sepsis is an infection, right? So infection, we think fever.
Right.
But actually what happens in sepsis is your fever spikes, but then your temperature drops. So a low temperature is sometimes seen with sepsis. I would say from my personal perspective that it is, if this person is in a obvious, probably decompensated stage of shock, you want to keep them warm.
Okay.
And I would say even warmer is...
Than you think.
Yeah. And warmer is going to be better than colder in my personal opinion and kind of my experience. So I would state that, like, you know, also like get them to the hospital. That's a treatment you need to do. Is time is important when you have like this decompensated shock. You know, I would, if you're talking about an ALS upgrade, I think it's maybe valuable just to think like what I'm going to do as a medic. So for hypovolemia, if their blood pressure, like if you're an EMT and you take a blood pressure and someone's blood pressure is over 90 systolic, I'm not giving them fluids. I'm taking them to the hospital. So maybe not waiting for ALS here might not be that beneficial. In terms of cardiogenic shock, I would say arguably this is probably where the paramedics can shine the most. You know, there's certain medications we can get. I mean, you could get fluid, and fluid will increase stroke volume to a certain extent. But there's certain medications like dopamine and push dose epi, which can increase the heart strength and speed. So we can increase heart rate and stroke volume. We can treat cardiac dysrhythmias fairly well. So if someone's in a fast heart rate, there's things we can do to slow that down. Or if they're in a slow heart rate, speed it up.
Do you feel like you do a good job at sharing some context in every unit or every chapter as to when might be a good time to upgrade to ALS? Because it's a hard concept to wrap your head around at the beginning of class.
Yeah, it's hard for me really to say when you should wait for ALS or not. I would think that, like, you know, the unwritten rule is, well, first of all, if the hospital's faster than ALS, you should always go to the hospital. But the unwritten rule is like, if you're less than 5 minutes away, will this person really benefit from ALS care or not? I can't say with accuracy. But I think that if this is a critical patient, meaning they really have issues, uncorrectable issues in their ABCs, and ALS is closer than the hospital, then you should get ALS. But if not, and we work in a very kind of unique EMS system. Those of you watching this video that aren't from Chicago or Chicagoland or even in an urban area, you call 911, you do not get a BLS ambulance here.
Oh, right.
I mean, nowhere.
Yeah.
I mean, there's like one, I can't even think of a BLS service anymore.
Just Maywood.
Maywood's the only one I can think of. Also, Stickney is BLS. But that just doesn't happen anymore. So when you call 911, you're getting a paramedic, but that's not the case everywhere in the country. So you might be kind of doing things like ALS intercepts a little more often. But I mean, if I was in a BLS unit and I would really have to say, well, can we get a ALS unit here quicker than I can get to the hospital? And that's kind of where I would draw the line.
We just try to check in and say, like, hey, ALS might have certain interventions in this context that might be favorable to the patient, pending your distance to the hospital.
I would argue a paramedic can do, I mean, just based on definition, this is no slight against EMTs. A paramedic can do more than an EMT can in pretty much every situation.
Yeah.
Maybe not in terms of treatment, but in terms of assessment, other tools, other tips. But I would say that if there's an issue with a non-correctable issue with ABCs, then like we should be thinking of ALS upgrade. Okay. And that includes level of responsiveness, airway, oxygenation, ventilation, circulation. So in terms of like something like this, like a distributive shock, there are medications arguably out there that can cause vasoconstriction, epi being one of them. But usually with this, we try to treat like the cause if it's like anaphylaxis, but this is another one we maybe give fluids to if someone's blood pressure is below 90. And then when we talk about the obstructive shock, probably the best thing we can do is relieving a tension pneumo with needle chest decompression, where we stick a needle in someone's chest, leaking that air out, which will kind of allow the heart to beat more efficiently. We talked about the pericardial stentesis, where we don't really do pre-hospital. And if you're considering pulmonary embolism, there's not much we can do there. So there are things that we can do as paramedics, but as an EMT, I think that your big job is not, your book says you don't need to know the cause of the shock. I think that's kind of bullshit. I think you should recognize what's causing the shock, but you need to understand what's more important. And what is more important is kind of treating your issues in your primary assessment, making sure you manage an airway, making sure you're managing ventilation, making sure you're managing oxygenation. If there's any, exsanguation, stop that bleeding, keeping them warm, keeping them flat. And that's going to do the patient a lot of good. But yeah, like I said, what it really all boils down to and what you need to do is you need to consider this. This must be supported. If this cannot be supported, then you can't survive.
Yeah. That was great. Anything else to add?
No.
Okay. Well, awesome. Everyone else, thanks for tuning in. This was almost an hour. But leave any questions or comments below, and we'll see you in the next one.
Yeah, maybe I shouldn't do the lecture and I should just send them the recording.